Ovarian cancer is one of those female genital cancers where the prognosis is usually poor. It ranks 5th in cancer deaths among women, accounting for more deaths than any other cancer of the female reproductive system. A woman's risk of getting ovarian cancer during her lifetime is said to be about 1 in 78, and most of the ovarian cancers, approximately 70%, are diagnosed at advanced stage where cure is uncommon. It ranks 3rd among the gynecological cancer and ranks 7th among cancers in women. So there are certain risk and protective factors for ovarian cancers as with other female genital cancers. The risk factors being genetic predisposition, family history of ovarian cancer, breast cancer, personal history of breast cancer, endometriosis, early age at menarche, late age at menopause, older age, obesity, hormone replacement therapy, white race, nulliparity, and infertility. There are certain protective factors also for ovarian cancer. They include oral contraceptive use, breastfeeding, tubal ligation, salpingectomy, bilateral or unilateral, and salpingo-oophorectomy. So, depending upon the family history, the risk usually varies. So, if there is no family history of ovarian cancer, then the risk of developing ovarian cancer is approximately 1.5%. First degree relative, it is 5%, and jumps to 35 to 40% if there are 2 first degree relatives. If there is a history of hereditary ovarian cancer syndrome, then the risk is 40%, and mutation in BRCA1, BRCA2, it is 35 to 65%, and if that is in breast carcinoma and BRCA1 and 2, then the risk is quite high, 55 to 87%. So in ovarian cancer, usually there are vague, non-specific symptoms responsible for late diagnosis, and that's why poor survival rates. Unlike endometrial carcinoma, where usually the patient presents quite early with complaints of irregular bleeding and excessive bleeding. Most of the cases of ovarian cancer, especially in the early stages, are asymptomatic. Some of the symptoms which are vague and not specific, seem not specific to ovarian cancer, include lower abdominal pain or pressure in the lower abdomen. Mass abdomen and abdominal enlargement usually comes late in the sequence of the disease. Then vaginal bleeding can occur, and urinary or bowel symptoms usually occur quite late. So, can the ovarian cancer be screened? It is said to be quite difficult to screen for ovarian cancer. There are some certain reasons for that. One is the anatomic location of the ovary, which is not easily accessible, unlike that of the cervix. And in case of body of the uterus, one can do endometrial aspiration. And then lack of well-defined precursor lesion, unlike there was L cell or H cell in case of carcinoma cervix, and atypical endometrial hyperplasia in case of endometrial cancer. And it has a poorly defined natural history. So these are not the prerequisites for prospective screening of disease. And there is low prevalence of this disease, and needs exquisite specificity to avoid unnecessary intervention. And then there is a lack of good method for screening ovarian cancers. So these are the various reasons why the screening for ovarian cancer is difficult. And moreover, that's why it is not cost effective. It may be considered, however, in case of high risk population for ovarian carcinoma, and at present there is no place for population screening. So ovarian cancer screening is recommended only for high risk patient and can be done by serum CA125 and transvaginal ultrasonogram. Few words about serum CA125. It is elevated in 82% cases of epithelial ovarian cancer and less than 1% in healthy women. And limitations are like lack of sensitivity in stage 1, that is early stages, and there is a poor specificity. It's also elevated in benign and other malignant condition. The same thing we can picturize like this. It can be false negative in case of ovarian cancer, because subtypes other than the epithelial ovarian cancer, the CA125 will not be elevated. Mucinous subtype, usually the tumor marker is CA19-9 or CEA. It can be false positive also, like it can be raised in breast, lung and gastrointestinal cancer. And then there are certain non-cancer conditions like pelvic inflammatory disease, endometriosis, pregnancy, cirrhosis, peritonitis and pleuritis, where the CA125 can be raised. So transvaginal sonogram is another method by which one can screen these cases. The features which are suggestive of malignancy by doing TVS include that it is usually bilateral, fixed, there is a variegated consistency, it's solid, there can be nodules in the pouch of Douglas, and hemorrhagic ascites may be there. However, sometimes it is quite confusing to label a case as benign or malignant. There are various other methods by ultrasonography by which one can suspect malignant ovarian cancer. So screening should be done for individuals with inherited risk caused by genetic mutation. However, there are no data demonstrating that screening improves early detection in women who carry high-risk genetic mutation. The present recommendation is screening with CA125 measurement and pelvic ultrasound every 6 to 12 months for women with Lynch syndrome starting at the age of 30 or 35 years. So coming to vulval and vaginal cancer, the incidence of vulval and vaginal cancer is quite rare. Vulval cancer accounts for approximately 5% of all gynecological cancers worldwide, and incidence of vaginal cancer is still lower than that, accounting for only 1 to 3% of gynecological malignancy. The annual incidence of vulval and vaginal malignancy are approximately 2.5 and 1 case in 1 lakh women respectively. And vulval and vaginal cancer, however, share many of the risk factors associated with cervical cancer. So, can there be screening for vulval and vaginal cancer? There is no simple and reliable way to test for vaginal or vulval cancer in women who do not have any signs or symptoms attributed to them. The Pap test does not screen for vaginal or vulval cancer, and there is no simple and reliable way to screen for any gynecological cancers except for cervical cancer. When vaginal and vulvar cancers are found early, usually by either early history or sometimes by examination one can suspect, then the treatment works best. Few words about screening for sexually transmitted infection. They should be identified using their sexual history. The opportunities for risk assessment may arise during consultations on contraception, or when the patient is coming for pregnancy or abortion, or when carrying out a cervical smear test, offering a STI test, or providing travel immunization. So in these cases, one can screen for STI. It can also be carried out during routine care or when a new patient registers. So one-to-one structured discussion should be done with individuals at high risk for STIs. So here we finish in short about the screening procedures in gynecology. Now coming to questions which we will discuss during next week on Wednesday. The first question is, at what age should the cytological screening for cervical cancer begin in sexually active women? At what age one preferably start doing HPV testing? Usually it is not done in the early stages. So after which age one should preferably start doing HPV testing? Third question, Enumerate various methods used for screening for cervical cancer, which we have already dealt in detail. Fourth is identify these two structures. This is a wooden structure and this is a plastic with a brush at the end. And it's used for what? So identify this jar which is used along with this in some procedure. And this cytofix, what is the function of this cytofix while performing pap smear? The next question is, which method of reporting is used nowadays for describing pap smear sample? That means once you have taken the sample and then it is fixed and then it goes to the pathologist. Pathologist follows a certain method of reporting. So what is that method called? Next question, what procedure is done with people curate? Ninth question, what are the screening procedures used for breast carcinoma? And the last question is, why is screening for ovarian cancer difficult, unlike that of the carcinoma of the cervix? Thank you.